Hello, everyone, and welcome. My name is Cora Peck. Today, we are joined by Dr. Chris Lakhiani, a board-certified reconstruction microsurgeon whose work focuses on peripheral nerve injuries and neuropathic pain, including pudendal neuralgia. His advanced training allows him to treat complex nerve entrapments and precision techniques designed to restore function and reduce chronic pelvic pain. Dr. Lakhiani, thank you so much for joining us. And we're also joined by Dr. Nicole Ferro, a board-certified physical medicine and rehabilitation and fellowship trained in interventional pain and musculoskeletal medicine, with experience treating chronic pelvic pain at the Institute for Advanced Reconstruction. So just wanted to welcome both of you and thank you so much for joining us. And I'm going
Thank you,
to go
Cora.
ahead and get right into it. So,
All right, sounds good. Thank you.
to start us off, can you walk us through your diagnostic process for pudendal neuralgia and how you distinguish it from other pelvic conditions that can look very similar?
Yeah, absolutely. So again, thank you, Cora, and to the group for having myself and Dr. Ferro here. It's been a pleasure to get to know many of you, and I look forward to getting to know more. This is a really tough and devastating condition, definitely exacerbated by the fact that there's no 100% clear path for patients with PN right now. Folks present very differently. The good news is that it's very similar to nerve compression disorders elsewhere that we have in the body. And so we think of it the same. So when you have someone with supposed pudendal neuralgia, and we're trying to find out if they have pudendal nerve entrapment, you really have to put on your Sherlock Holmes hat for a while to figure out what is their cause of their pelvic pain. And unlike the arms, where you have hand surgeons who know about nerves, tendons, muscles, bones, etc., in our pelvis is very complex. We not only have our nerves, but we also have our reproductive system, our endocrine system, our urologic system, our GI system, but also our hips, our joints, labrum, etc. So there's not one master of it. It's a combined decision making and analysis with GYN or urology, orthopedic surgery, potentially spine surgery, physical therapy, and myriad other specialties because there's not a master. So we definitely rely on our colleagues and other specialties. So I'd say that's probably number one, Cora, is that when I get folks, um, whenever someone tells me they have pelvic pain, pudendal neuralgia is really not the first thing that I go to. The common things being common: endometriosis, um, bursitis, um, musculoskeletal inflammation, prostatitis, varicoceles, etc., are much more common. So the first thing I look for is what has been their medical history. And it starts with that, going through and getting a complete detailed history. When did your pain start? What has aggravated it? What has made it better? What makes it worse? Being very honest about those. And then we can sort of start to narrow down the field of what could possibly be causing this pain. In general, when pain is focal and it's limited to specific areas over and over again, and it doesn't tend to migrate, meaning one day it's in the genitals and then it's in the abdomen or the leg, focal pain that we can reproduce with an exam is much more reliably treated. So the next step is just to do an exam and see if we can recreate someone's pain. Pain that is recreated is often a structural issue. So once we've kind of identified that, hey, this is a pain, it's in one spot, we can recreate it, that's when we move on to getting imaging. And our imaging now we can focus to that area to know what type of imaging we need. Because if they have a hip issue, they need one type of MRI. If they have a lumbosacral plexus issue or PN, they need an MR neurography. So the study type varies depending on what we think. And then finally, once with our imaging, our history, and our exam, we've narrowed it down to a few different conditions. We'll use selective nerve blocks or muscle blocks to isolate what the cause is of their pain. So in general, someone with PN, when we're finding it, we rule out everything else. We get imaging to see if there's any sort of proximal level. What that means is Do you have something that's sitting on your nerve by the spine or in the pelvis that could be mimicking pudendal neuralgia without being pudendal neuralgia? And then we confirm it with a block.
That's great. And then, so many people struggle to understand why pudendal neuralgia develops. And I just wanted to ask a few questions about some common causes. So we hear from patients whose pudendal symptoms begin after things like maybe a dislocated tailbone, chronic pelvic floor tension, inflammatory conditions like maybe colitis. Can you explain how these types of issues can contribute to PN?
There's two types of explanations here. One is like, what is their rock solid evidence and what is hypothesis? If we go by what is established evidence, those things generally aren't directly linked in the literature. That being said, for folks that do pelvic pain treatments or nerve surgery in general, there's something that happens to folks when they have any sort of trauma or inflammatory issue, which is they're predisposed to nerve compression issues. If you break your arm, you're predisposed to having carpal tunnel syndrome. If you break your leg, tarsal tunnel, common perineal nerve issues. If you have any sort of surgery on your arm or leg, the same things happen. Um, so when I have folks that have, for example, broken their tailbone, because we get coccydynia with PN a lot, interestingly, what we find is that in a lot of folks, when we fix the PN, their coccydynia goes away. So I just want to be careful about conflating the cause and effect here. Sometimes the cause is thought to be a tailbone issue and then causing inflammation, maybe, or destabilization if you've had a fracture. This is again hypothetical. Destabilization leading to muscular ligamentous malalignment, irritation of the sacrospinous and sacrotuberous ligaments leading to pudendal nerve, either irritation or entrapment. Um, but that's more conjecture. I think one that nerve surgeons would believe, but you're not going to find in a textbook. Um, Colitis, again, you're not going to find that in a textbook that colitis leads to pudendal neuralgia. I can't think of any literature that shows that, but I will say that referred pain and anterior abdominal pain through connections that the pudendal nerve sometimes has with the iliohypogastric nerve can lead to lower abdominal pain, sort of pubis area pain feelings that people may have attributed to abdominal pain that actually could be a variant of pudendal neuralgia. So man, it's like I could talk all day about this question,
Right.
what causes PN? The classic things that I'm sure everyone on this call knows are the obvious ones: cycling, motorcycle riding, horseback riding, trauma to the pelvis, any sort of straddling activities, pregnancy, childbirth, um, gynecologic or urologic surgery, ischiorectal fossa abscesses. But there are certainly these other conditions which are a bit more nebulous. It's obvious to say, wow, you had an infection right over your pudendal nerve. Of course, that causes pudendal neuralgia, pudendal nerve scarring. It's going to take much longer to prove, for example, oh, you have pelvic dyskinesia, which is an imbalance of the muscles of the pelvis causing sacrotuberous ligament tightness leading to pudendal neuralgia. That kind of second or third order thing is going to take us time to prove so.
And then, is there any reliable way to distinguish pudendal nerve irritation versus true entrapment without having surgery? And are there
Yeah.
specific signs or symptoms, maybe patterns that help you tell the difference?
Awesome, awesome, awesome question. Like I tell all patients when they come in, I say you can't have pudendal neuralgia without having pudendal nerve entrapment. For example, I know there are a bunch of questions on cysts, and those are great questions. But if you have, for example, a perineural sheath cyst, and it's 3 centimeters, and it's sitting on your S3, you're gonna feel like you have PN. But if we do pudendal nerve decompressions, there's less of a chance of it helping you because the problem isn't the entrapment. The problem is you have a cyst sitting on your nerve that's causing compression at the nerve root. So sometimes distal decompressions, whether we're talking about this problem in the arms and the issue is in the neck or in the legs because the issue is in the in the lumbar spine. Um, Distal decompressions can be used for pain, but you're not taking care of the main problem. So
And
that's what I'd
actually,
say about
kind of leads into this next question. Someone asked, how can you differentiate PN nerve entrapment by Tarlov cysts in S2, S4, and that's including PGAD as a symptom?
it. What a great question. Okay, so I didn't finish answering fully nerve irritation. And if I take 15 minutes to answer every question, I'm sure we'll be here all day. So sorry. I just love this and I could talk about it forever. So nerve irritation, just to finish that thought, when the nerve is irritated, it'll usually be irritated along the whole course of the nerve. So in our exam, what most people will find is that I am running my fingers over the entire course of the nerve from the sciatic outlet to anteriorly to try to see if I can find one point that is worse for their pain. And all nerve compression disorders share this unique and fascinating fact. That's the point of compression tends to be the point where they have reproducible pain and a Tinel sign. A Tinel sign is causing a shooting or a zinging feeling when you tap the point where it's compressed. So if people have carpal tunnel, we tap their wrist and it causes a zinging, shooting, or pain feeling. Um, but if they have a median nerve neuritis, they also have pain here. But when I press the nerve here, it hurts, and here 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 it hurts. And if you talk to our patients with that, sometimes when they get decompressions, it goes from the neck down into the arm, into the brachium, through here, and all the way into the hand. Very big incision. That's because the hand has many different compression points, and our pudendal nerve has many different compression points and locations that it can be irritated or triggered, which I'm getting back to the cyst thing. And so the cysts, they're sitting at our breaker box, right where the nerve signals originate, either in the spine or on our dorsal roots. So the studies that have looked at Tarlov cysts, for example, in terms of pain, there was one study that looked at about 240 people, and it showed that having the cyst was not predictive of where your pain is or what type of pain it is, or even that you'll have pain, even though they did find that patients with this type of pelvic pain had a higher incidence of Tarlov cysts.
Okay.
But that being said, people with PGAD specifically had a much higher incidence of Tarlov cysts at their S2. So specifically for PGAD, Tarlov cysts may play a bigger role. But for all other nerve disorders, unless you see that the cyst is so large that it's compressing the nerve root at the spine, probably isn't going to be something that any neurosurgeon would recommend treating.
Okay. I wanted to clarify something because it occurred to me. A couple people in the group um, were confused. I know you are technically a plastic surgeon, so you don't do any internal exam for patients. And do you happen to know if there's a difference in what people find when they do internal exam versus external in terms of compression points? Do you find that you're missing
So
something or
it's all about if you feel like you can examine the compression spots.
okay,
In 99% of people, I feel like I can examine Alcock's canal and the distal sacrotuberous ligament and the piriformis area transcutaneously.
okay,
In some people, if they have a very wide habitus or thick, then you probably do need an internal exam to palpate that area. Um, an intravaginal exam is very rare for me, unless I think they have a suspected very distal entrapment by the transverse peroneus, or if there's someone who had, for example, we get patients who had episiotomies or neuromas that occurred after tearing in childbirth, and they need an internal exam. Those folks tend to have direct pudendal nerve damage, not a compression.
okay. And then what role does SI joint dysfunction play in pudendal pain?
Part that it plays is probably most that it's a mimic. So it's a coexisting pain generator, I should say. So it can distort pelvic mechanisms, but it doesn't directly contribute to your PN. We're kind of getting into that pelvic dyskinesia argument, which if you talk to 100 orthopedic surgeons, 50 or more might say, I don't believe in that. I would probably disagree, as I am someone that operates in the realm of more unusual things. I do think that the muscular forces on our hip girdle play a role in pain. We're finding in the upper extremity, and Dr. Ferro does a lot of this now. There are people that have complained of headaches, ear pain, jaw pain, neck pain, and actually it relates to tightness of the pectoralis minor muscle by the shoulder, so shoulder muscle causing jaw pain. And that is a dysfunction of the upper girdle. So one muscle tightness causing many nerves to get inflamed and irritated, causing pain. And by cutting one muscle, a lot of that pain is relieved. It's called the human disharmony loop. I think that something similar occurs in the pelvis. And I do think there's people who have certain muscle imbalances that probably lead to this. The problem is we haven't mapped all of that out yet.
Okay. A couple of these are going to be very related, but some patients notice that they have vaginal pain that worsens, and all of a sudden, like their knee pain worsens, or they have leg pain. And is that something that you find that's pretty common with patients with PN?
As someone who treats pain all the time, when you have pain or stress, all your pain and stress is exacerbated. There's no direct linkage mechanism from, well, except for this offshoot, okay, which I'll talk about, but there's no really one direct linkage. What I often hear is my PN pain is really bad when I'm stressed, when I'm studying for exams, or have a big of a deadline at work, or I have problems at home, or when I have another pain. When my PN pain is bad, the other pains can be bad too. Some people are different. The pain is so bad they don't even realize there are other pains, and then you take away that pain and they're like, oh yeah, I did have this leg pain and now it's back again. Um, so what I'd say to that is pain is very complex. I would not try to go looking for a single Occam's razor, one causative explanation for every type of pain. Even though we love that, when it's regionally focused, it's easier to make that deduction. There is one instance, which is if you have coexistent piriformis syndrome and pudendal neuralgia, that you could have leg pain with PN, but not specifically just knee pain. Your knee innervation comes from mostly your femoral nerve. So I wouldn't really cause that.
Speaking of which, next question. We often see many patients with overlapping neuralgias, such as pudendal, genital femoral, lateral femoral, cutaneous. Um, is there any anatomical explanation for this, or are they not related?
I wish I knew the answer to that question.
Yeah.
That's one we would all love to have. I have some patients that come to me with isolated, it's just one nerve, it's just their PN. And as you said, some folks, it's a lot. Sometimes there's an obvious trigger that did it. Like we've taken care of folks that have, pelvic trauma or car accidents and things, and then it obviously makes sense. Why do people get these from seemingly benign lifestyles or sedentary existences? It could be a postural related issue, how we sleep at night. It may just be bad luck. I imagine it's some combination of nature and repetitive stress activities that we do every day. Um, but outside of like an obvious thing, I don't have a good
Yeah.
answer for you. What I would recommend to everyone though is stretch, every week, a few times a week, if you want to try to prevent a lot of these issues. A lot of these problems of dyskinesia are an over tight muscle or ligament, and you can prevent a lot of these by just stretching.
And then another question, somewhat related, is it possible for the pudendal, sciatic, and femoral nerves to be entrapped in the same region? And do you see that when you're in there surgically?
One, yeah, pudendal, sciatic, and posterior femoral can be entrapped in the same region, but not the femoral,
Okay.
because that's on the front of the leg, but the posterior femoral. And yes, I see that all the time. It's essentially the proximal originating fibers of the piriformis, where they invest onto the sacrum and over the sacrospinous ligament. The nerves, as they exit from there, can become entrapped in this thick web, and you end up having pain in your genitalia, the anus, down the back of the thigh, and then also below the knee to the leg. That's because the sciatic nerve innervates below the knee to your feet, and the posterior femoral nerve innervates your thigh.
And then do you encounter cases where there are engorged or meandering pelvic veins compress the
Yes, and
pudendal
this,
nerve?
sorry, I got so excited, you see, because this is
And how
like
do you address it?
you have to address this. This is the big key. I think a lot of literature the last 10 years has shown the effect of veins on pudendal nerve entrapment. Unlike most of the nerves in our body, the pudendal nerve runs in such a way that the veins can wrap around it like a boa constrictor. So most of the time in our body, things run like this, like three: an artery, a nerve, and veins. Usually two veins and the artery and nerve, and they just go together. In the pudendal, they go together, except this vein sometimes corkscrews around it, and it can be really bad. Whether you have pelvic congestion syndrome or not, these veins can be contributing literature-proven factors leading to nerve entrapment that we have to take care of in folks all the time. And it is why I think certain people benefit from the open microscopic approach, because that's probably, at least for me, it's the only way I know of that you can strip these veins off of the pudendal nerve should you have them. So not everyone has this, but if you do, I think that'd be hard to do without an open approach.
So now I just want to cover imaging and diagnostics. This comes up a lot in our group. What imaging modalities do you find most useful for identifying pudendal nerve compression? And how often do you see cases where imaging appears normal, even though you later find compression during surgery?
Yeah, it's tough because we get an MRN for most of our patients, an MR neurography, and usually we partner for the folks that can do it with Daryl Sneed and Hollis Potter, who are at the hospital for special surgery in New York, and they're excellent physicians, and I think have really tried to move the needle forward in terms of MR neurography and pudendal nerve disorders. That being said, even if we speak to them, the vast majority of patients will have normal imaging with a nerve entrapment disorder. That's true of the pudendal nerve, but also every other nerve entrapment disorder in the body. Here's potentially the good news. You kind of want that. Once your nerve is so severely entrapped and swollen that it's showing up on the MRI, it's a pretty late stage finding. So we definitely have patients that have hyperintensity of the pudendal nerve on T2. It's swollen, it's filled with water, you can see it, and they definitely need a decompression. But even without positive imaging, surgery is still acceptable. Mostly we're getting the imaging to make sure that someone doesn't have the things we talked about earlier. Because if you do have a perineural sheath cyst sitting on your S3 and we do pudendal nerve decompressions and you don't get better, we're going to be scratching our heads. But if an MRN has showed that, at least we'll know, listen, let's not keep chasing doing more surgeries and distal injections and amniotic tissues and things of that nature. This is a cyst issue. We need to find a neurosurgeon willing to decompress that cyst to try that. Finding a neurosurgeon willing to do that is not always easy.
Yeah, there doesn't seem to be a lot of them in the United States that do that. I know a lot of patients have difficulty, especially with Tarlov cysts, that some even don't suggest removing them.
They don't,
Um,
yeah. And I agree with that. A lot of the small ones, I would just leave, Here's the thing with spine surgeons, and I love my spine surgery colleagues, but sometimes when folks do get a consult with them, one thing that I hear is they say, well, they said nothing's wrong. But often there's a difference between nothing's wrong and there's nothing I can do. And that's a key distinction in pain and pelvic pain that I want everyone to definitely keep in mind when your doctors say that to you. Just try to ask them, pry a little bit. Well, is there something that's an issue and you just can't do anything about it? Because that's totally different. That could save people years and years and years of time if they just know there is a problem right there.
yeah. So this next one, why aren't MRIs or MRNs performed standing, especially when many patients have less pain um, lying down?
Great question. I can't say I know the answer to that one. I think just when they built MRIs, they thought it's better for people to lie down if you have to lie down for a time. I know that they have some open MRIs now and standing MRIs now at certain facilities. The MR neurographies, you need a higher magnet. You can't go into a regular MRI machine. So they have many fewer standing MR neurographies in this country than they have regular MRI machines. I I actually can't think I know of any off the top of my head for a standing MR neurography. Um, but definitely, if someone knows that, definitely let me know. I would love to tell people about it.
All right. And then now, if you could tell us a little bit about the diagnostic tests that you consider most helpful in confirming entrapment.
Physical exam, history, pudendal nerve block. And we'll have Dr. Ferro, who's on, is our injector, and she does hundreds and hundreds of these a year. She's absolutely amazing at this. But when the reason I like how Dr. Ferro does it is because she uses a very small amount of anesthetic, and I won't steal her thunder. I'll let her talk about this. But if you have a small amount of anesthetic that numbs the nerve and your pain goes away, it's probably the nerve. Or, big caveat, it's a problem that's distal to the nerve.
Right.
Okay. So, like if you block it at the ischial spine and the problem's at the base of the penis, you'll still go numb, but we might do your decompression at the ischial spine and you won't get better because the problem is you have that more rare kind of compression at the suspensory ligament of the penis, the fourth site of compression. So little caveats here.
So, Dr. Ferro,
Dr.
could
Farah, I
you?
don't know if you could talk more about
Yeah.
diagnosis and what your experience has been in terms of diagnostic testing.
Yeah, so I do the pudendal nerve blocks, like Dr. Lakhiani said. I use actually two modalities to do one block. So I'll use X-ray and ultrasound. And to me, it just gets a better block because we actually have patients that have come and have had multiple where they don't experience any numbness. And, that's even sometimes with CT guidance. And it's typically, I guess, because the nerve was just missed or the block was not placed properly. But when I use X-ray and ultrasound, so I'll do the block at the level of the ischial spine using X-ray, and then I'll use the ultrasound to identify the nerve a little bit further down at Alcott's Canal and just put a few more cc's of lidocaine. That just ensures, because I'm kind of coming at the nerve from two different sides, that will get the numbness and get an appropriate block. And then if the best way is if you have pain coming in, so if you can tell me that your pain level is like a 6 out of 10, for example, and then we do the injection and you get the numbness and your pain decreases to maybe a 1, that's a pretty successful block and a good response to it. So that helps us with the diagnosis. But there is a lot that goes on in the pelvis, and we both, myself and Dr. Lakhiani, continue to learn about this daily. When I say that we're just scratching the surface of what we can do, that's you know that that is the truth. And we're trying to combine disciplines. So right now I work with an OBGYN who is helping me. I also do not do pelvic exams routinely, and I relied a lot on the pelvic floor physical therapists to help me, identify, because you see them more routinely. They work with you all the time. They can tell me if there's muscle tightness, or they can identify different things. But actually, now I will start doing pelvic exams more routinely, because I have learned from an OBGYN, what to identify, and how to more appropriately do those. But um, yeah, in terms of the diagnosis, the nerve block is just one part of it. Everything's just a different piece of the puzzle. And when it comes to pain in general, there's so many factors that nobody's pain is the same. Everybody has a different experience, and there's just so many things that can contribute. But our, I guess, end goal is, like Dr. Lakhiani said, if there is an identifiable nerve compression that we can isolate for this specifically, pudendal neuralgia, that's what we're trying to do. Eliminate all other possible causes and try to specifically identify it, so that way you get the best outcome with nerve blocks and surgery.
And do you use steroids in the blocks, or do you just use lidocaine for the diagnosis?
It's case by case, but typically I will use some steroid. I feel like, so when I do the block at the ischial spine, I just use the numbing medication. Um, the reason being, the most common area of entrapment is at Alcock's canal. So at Alcock's canal, I put um, a small dose of steroid, because I feel like if I'm going to do the block, especially when we have people that come from out of state and they can only see me one time, if I can get them some additional longer lasting relief with the anti-inflammatory effects of the steroid, I like to put it in. But there are people that don't want it, and that's fine. And I don't have to use it, but usually people like that, and so that's what I'll do. I'll just put it at Alcock's canal.
And do you have any patients that complain of any side effects or anything after the blocks?
So the one thing that, I can never guarantee that after the injection, your pain could potentially get worse. Reason being is that when you're in pain for so long and you experience numbness and you have that pain relief, once the numbness wears off, your brain sometimes has a hard time interpreting the signals afterwards, because it all just comes back like like a tenfold. And so sometimes people can get this rebound pain effect where they're like, oh my gosh, it feels worse, because when you have that moment of numbness and relief, and it feels so good, then once your baseline level of pain comes back, it can feel worse. So sometimes that does happen. It doesn't happen to everyone, but it can. So I would say that that's probably the biggest side effect. There's also the possibility that the block's not going to work for you. We could numb the nerve and you might still have your same pain. And so, outside of that, anytime you have an injection, there's risk of bleeding, infection, but it's really low risk, less than 1%. It's a pretty safe procedure, but yeah, your pain could potentially get worse for a week or two afterwards. And I'll usually just give like a steroid dose pack if that happens.
And then, Dr. Lakhiani, when you get results from the block, how do you determine if you move forward? Do you say, okay, like let's say the block is negative. Do you then decide that's for sure not PN, or do you have people try it twice just to make sure? How does that work?
Yeah. So we consider a successful block greater than 50% pain reduction. Anecdotally, I tell folks that the amount of relief you get from your block is about the maximum that you should expect from surgery. Surgery can't do better than numbed and paralyzed nerve. Um, if you get the nerve block and you go numb and you say, yeah, guys, it feels like rubber down there, and we'll often do bilateral blocks, often just for this effect if people haven't had them before, because sometimes with one, it's hard for folks to tell. So we'll just say, let's do both to make it easier for you. But if you get those and you come to us and you say, it feels like rubber in my genitals, but I still have my pain, well, then we think you probably don't have PN because they got the nerve. We'll try it again. But if you have negative blocks and you have numbness, then it's probably not PN entrapment, at least at that level. You could still have pudendal nerve symptoms from other things, spinal issues, piriformis syndrome, cysts, central sensitization, fibromyalgia, CRPS type things. But that's what we would go by. We wouldn't do surgery for those.
Okay. All right. So now we're going to switch a little bit. Could you walk us through the pudendal nerve anatomy and how different injuries or entrapments affect the different branches?
Walk us through. Okay, I got what you're asking for this one. Yes, so the pudendal nerve comes S2, S3, S4 from our spine. It coalesces together to make the nerve. It then exits through our sciatic outlet. That's the first point that it comes into the field of view for anyone to really operate on. You can get it into the sciatic outlet a little bit, but it gets very dangerous in there very quickly. And there's a lot of horror stories about that area. So the first spot is there at the proximal originating fibers, right as the pudendal nerve is exiting its home. It's like that. You see that National Geographic with the lizards that run, but the snakes get them. That's how I feel about the pudendal nerve here. It's running out, but the piriformis just grabs onto it right away. So that's entrapment point number one, is the proximal fibers of the piriformis. And it can be either those fibers or it can be the underbelly of the piriformis tendon. That's why sometimes you've read about people that were diagnosed with piriformis syndrome related pudendal neuralgia, and they got something called the piriformis tenotomy, which some people have had that works, where you just cut the tendon of it, but it didn't work. It's because the nerve is trapped inside of the fibers of the piriformis. Usually that one will present more with pudendal symptoms, groin pain, anal pain, and leg symptoms, whether posterior femoral cutaneous or sciatic nerve. So maybe burning in the back of the thigh or burning down to the leg, just depending on what is trapped in there. The second spot is the one most people are more familiar with, is the interligamentous space between the sacrotuberous and sacrospinous ligaments. This is certainly a compression point. The sacrotuberous ligament, if we have someone facing down, the sacrospinous ligament is low and the sacrotuberous ligament is up top. The pudendal nerve, as it's finding its way over here, in some people goes like this, and it's between the sacrotuberous and the sacrospinous ligament, and it's not compressed. In some people, it's here in the crook of it, and it does get compressed. And sometimes you need to cut one or both of these ligaments to get it. This presents as the classic nonce criteria pudendal nerve entrapment. The third type is Alcock's canal level entrapment. And Alcock's canal usually still gets all branches of your pudendal nerve. However, sometimes the anal branch is spared because it originates higher. So those types of folks may have more distal symptoms. Lastly, or not lastly, there's actually two more. There's the next one, and these are the more uncommon pudendal nerve entrapment points that folks may have not heard of, but there's the perineal membrane and the transverse peroneus muscle. That area is past Alcock's canal, and that tends to give more specific, like perineal pain, like a stabbing pain in the perineum, often with a feeling of like muscle pulling or tightness. In this low ischial rim area, there's also something else that can happen pretty rarely, but it's called an ischial tunnel, and it's a tunnel essentially through the bone, or through a little rim of periosteum in the bone that can entrap often the dorsal nerve. As that travels the ischial rim, it can then get stuck again, the dorsal nerve, at that rim, and under the suspensory ligament. So there are these more minor sites, and that one, we have definitely been doing a lot more of. Folks will often say, well, let me rewind it for just a quick second. So there's multiple sites: piriformis, sacrotuberous sacrospinous ligament, alcox, transverse peroneus, and then what I'll call dorsal nerve compression points. Okay. So depending on where it is, you'll either get everything, including the leg, just the pudendal nerve, just some of the branches. And the further you go, you get some of the branches. If you release your nerve proximally just by the piriformis, it's possible that you could just fix the leg symptoms and their pudendal symptoms would get better, but then they would swell on the pudendal nerve and it might then get entrapped at your sacrotuberous sacrospinous ligament or alcox. So then you might come back and release them at the ligaments or alcox. But then they come back 3 to 6 months or a year later and say, you know what, the base of my pubis hurts a lot, or the base of my penis hurts a lot. And it's because now they have an entrapment of the pudendal nerve at the suspensory ligament. So it's an evolving process. And the reason why there isn't just one approach is because it depends where we have to get the nerve. Sometimes you have to get the nerve way up by the piriformis, and I make a different incision. Sometimes I have to get it by the base of the penis, and I make a totally different incision. Most of the time, we're talking about alcox, sacrotuberous, sacrospinous, what we all normally think about as PN. Um, and I know we think that the alcox canal is probably the most common site of entrapment. I know that's controversial, but we've written and presented that work, and I think that will be telling in the next coming years as we amass more patients to show that.
All right. This one's a three-parter, but can the pudendal nerve be irritated at the sacrotuberous ligament without being entrapped? For example, causing like a golf ball sensation. And if so, do you sometimes have to shave that ligament? And can that irritation later lead to adductor tendon pain? It's a very long question. Sorry.
I saw this question and I like this question a lot. I really like these like second and third order processes of like what happens. The problem is that they're just starting to discover these for the neck and arm. And as you guys may know, the pelvis and legs are like 20, 30 years behind the neck and arms in terms of surgical funding and research for people to develop these things. So, anyways, the short answer is I'm not sure what the first question means. Irritated, but not entrapped, but still shave. So it can be irritated, but not entrapped. Um, like we said before, I only shave it if it's entrapped. Um, Cutting the ligaments can lead to theoretically some kind of dyskinesia, theoretically. Um, but that is that's definitely not proven science. There's an indirect biomechanical link to it, but I haven't seen any study from this.
And then do you decompress every nerve related to the perineal branch, and do you routinely check the other pudendal branches during surgery?
Yes, I check every branch.
Okay. All right. So before we get really into the surgical aspect, I wanted to add this question in for everybody. So before someone considers surgery, what conservative treatments do you feel are most effective for PN, and how do you decide when it's time to move away from conservative care and go towards surgery?
I think PT, pelvic PT, and steroid injections are probably most efficacious. Our algorithm is that we try those first, and we'll try, usually 3 nerve blocks with steroid. Tell people the reason being, if we think this is a nerve entrapment, Steroids are used to help reduce inflammation, keep the nerve from pinching itself by reducing swelling, so that restores blood flow to the nerve, which allows it to heal, which breaks the cycle, which relieves the pain. If after 2 or 3 of these blocks with steroid, you have no effect, then you're probably not going to get effect with 3 or 30 more. So we move on to surgery, because surgery is, if we really suspect that this is an entrapment, the only thing that's going to restore blood flow to the nerve so that it can heal itself and resolve your pain. The other modalities that have been described, like ablations, stimulators, pain pumps, um, don't really address the root of the pain. If you talk to some people about ablations, they might say that it causes myelin regeneration and maybe that's healing the nerve, but I don't think anyone would really say that it relieves a true compression. So that's why we move on to surgery second, because it's really the only thing that we know that has the ability to heal. PRP, amniotic tissue, some other things have been attempted as well. These all have their role. PRP has been described for this, which is platelet-rich plasma, but it has an efficacy rate of, I think, 10% the last I checked. How are stem cell, even let's say real embryonic stem cells, how are they going to help a nerve entrapment? I don't see a clear mechanistic explanation for that. So we don't use nerve injections and things to treat carpal tunnel syndrome, cubital tunnel syndrome, peroneal neuropathy, tarsal tunnel syndrome, occipital neuralgia. So we just treat it like every other nerve disorder and release it, and then use those things as salvage procedures if the surgery doesn't work.
Okay. All right. So let's get into surgery. So who is a good candidate? Um, so what would be your ideal candidate for surgery? What would they have to check off?
Someone's had their symptoms for under 2 years, has done PT for several months, has a positive response to a nerve block, with it lasting at least several hours, even better if it lasts longer, a day or two. And they have to have a discrete source of their pain on physical examination. If I can point with one finger and press in their ischiorectal fossa and find a point with pain, and I move an inch up and they say there's no pain there, and an inch down and they say there's no pain there, then that's a problem for a surgeon. That's where the thing is, and I got to fix it,
Yep.
and I can get it. Once folks have pain there, but I also press on their lateral thigh and they have pain, their lower thigh and there's pain, the lower back and there's pain, the other side and there's pain. And now we start to get very dicey, even if they had a positive response to the nerve block. Now it's way less clear, right? I don't know if it's more of a fibromyalgia or a central sensitization, or sometimes someone has just been in pain so long, they are just everything hurts and they're just desperate and they're just trying to cry for help. And like, I get it. But it's not gonna help lead us to the right direction, in other words. So that's what we love.
Okay. So judging by what you're saying, I'm assuming then patients that have had it for 2 years or under, you've probably seen them have better outcomes. So
Yes, and we've presented that research.
So what about those patients that have had it for longer? Because there's a few people in this group I know that have had it, say 10 plus years. Would you still consider them for surgery?
With all nerve compression disorders, the longer until treatment, the worse the outcomes. The reason is because it's like an area under the curve calculus thing, right? As time goes on, if this is our triangle, as time goes on, related to pressure here, more axon death. So high pressure, short time, high axon death still. Low pressure, long time, high axon death. High pressure, long time, terrible result. Nerve's not going to have much of an outcome. So we know time, but we have no idea what the pressure is. Nobody knows what the pressure is. It's impossible for us to find out right now if you have zero point 0.5 psi on your nerve causing you pain or 50. So that's the limitation is we have no way of assessing the viability of a nerve before the decompression. So I would say if you still have a positive response to a nerve block, it may still be worth it for people that are clear-eyed about the potential outcomes if they've had it for over years. We do still try it. That being said, it's the possibility for worse outcomes is much higher. It's around 80% if you're under 2 years. You're getting to less than 50% at 10 years. That's still, listen, if I had this pain, I'd probably take those odds. But the longer you go, you also run the risk of the surgery causing worse pain. The hypothesis being that now you've decompressed the nerve, part of your fibers have started to transmit, but they're shoddy, they're not working well, and you have worsened chronic pain. So it's important for everyone to know that stuff, especially if you've had this a long time. And you have to have, I'd say if you've had this for such a long time, you need to have a pain management physician in place to help you afterwards. You need to have a backup plan. You need to have a backup plan no matter what when you do this procedure. But in this case, you definitely need to have a backup plan kind of ready to go for those patients, whether it's a peripheral nerve stimulator or a pain pump or repeat Exparel injections or something.
Okay. And speaking of, you mentioned percentages, 80% success for people under 2 years. How do you define the term success? And what do your success rates look like based on that definition?
Yeah, we call that success greater than 50% reduction in pain. And so that's pretty much like the standard in nerve surgery of what we use for like defining success and pain when we write literature to communicate it to folks. Our study results and this was our first cohort of patients in my first 3 years, I think, doing this. But we looked at people who had at least a year or two follow-up and 75 to 80% successful if under 2 years. It's more like 70, 65 to 70 if you're around the 5 year mark. And then after 10 years, our number was low. So I can't give a percentage, but the success rate was much lower. So get there early is really, and that's been proved by multiple authors, not just myself.
And I noticed earlier you mentioned central sensitization. Um, how does central sensitization affect candidacy? And can a patient with significant CS still benefit from surgery?
I think that's an evolving question. We didn't really have even a good screening tool for central sensitization until recently. And at Harvard, they released a new criteria for this, which we're actually going to be implementing in our practice as well. If you have CS, everything must be approached with caution. It's very hard to diagnose CS. It's a diagnosis of exclusion. B, it's very hard to tell someone, I think you have CS. I'm not going to try surgery on you. Um, so the CS is one of these things where you have to like your surgeon and you have to be a team and you guys have to participate in the decision together because I don't think there's any expert in the world today that says that they have this figured out.
So during surgery, what complications can occur and what percentage of patients experience each?
During surgery, uh, the only thing I guess that could complicate it is if you have bleeding, that's in excess. You accidentally cut the pudendal nerve, which thankfully we've never done, knock on wood. Um, or in a man, it can be devastating if you cut the pudendal artery because that can contribute to impotence. So you have to, whenever you do men, you really have to make sure that you decompress the pudendal artery in addition to the nerve, because oftentimes they'll be dealing with ED related issues in addition to this pain. and decompressing the artery can augment their blood flow.
And do you operate on patients who previously had failed decompression surgery?
I do. I do. I have the last like 2 years or so started to offer that to folks. If I do a repeat decompression, I only really offer a complete, what I call a completion neurolysis. So let me tell a quick story. When I started doing this, I got really moved about it because I had a patient come to me and she had her pudendal nerves treated by another physician who accidentally severed them after he and cut both sacrotuberous and sacrospinous ligaments, leading to pelvic instability. It really scared me from cutting the ligaments for years. Um, so she came to me and, at this point was devastated, incontinent, and in pain. And so we honestly talked for years before we did anything because it was such a high risk thing. I don't know why she chose me at that point. But we did re-explore her and do the completion neurolysis, which means it's a big incision. I have to open up the piriformis, the ligaments, Alcock's canal, everything. And then we did nerve grafting, like I was doing earlier this morning and yesterday. A lot of nerve grafting lately, to bridge her pudendal nerve. And actually, we're able in this patient to cure her incontinence.
Wow.
And she still has serious PGAD, but where her pudendal nerves were crushed and cut, we at least fixed that continence. So I've now done many more secondary revision decompressions. This is again another one where if you come to me, just make sure we're friends and like your surgeon. This isn't easy surgery. It's not a path that has been laid out before, and that's why I like to be upfront about this. But that's a lot of reconstructive microsurgery is trying to design a boutique solution for your patient. Um, so when I do this, I open from the piriformis ligaments, Alcock's, it's everything. The reason being because you don't want to go in a third time. Every time you have surgery, you're going to put some more scar tissue. Even with all the fancy new stuff we use to help mitigate scar tissue, your body only gives you so much healthy, native, virgin, untouched tissue that your mother gives you when you're born and grows with you for life. And whenever a surgeon has touched it, whether that's with Botox and fillers with injections or a knife, that tissue changes. It's not the same. Call it scar tissue, fibrosis, whatever you want, but it's not the same quality tissue. And if to go back in a third or a fourth or a fifth time on a pudendal nerve area is risking making someone incontinent very seriously because the fibrosis is white and the nerve is white. So it's just like digging through white sheetrock. So that's a long-winded way of saying I do it, but um, we have to be friendly about it because I may have to do grafting, I may have to do a big incision, and we may not get a great outcome. It totally depends on what we find in there and what the status of your nerve is.
And to go along with that, do you ever switch up your approach with a patient?
Yes.
For instance, like say somebody came in and had laparoscopic surgery, would you go in and do, you know, your version or like the traditional transgluteal version or vice versa?
So I don't do any laparoscopic surgery. I'm not trained in it. I am thinking about robotic applications for approaching the pudendal nerve. But again, I don't think we're going to be able to solve the issue of incision length because too many patients have a vein problem and you just can't treat those veins, with long instruments. You need to see them, you need to dissect everything off of them. And these veins are about 0.7 millimeters in size. So you can't just pick it up with most instruments. So um, if you have had a laparoscopic decompression, I will happily take you still and do an open decompression. I can do that. And actually, that in some patients that has worked where I've done combo things with other surgeons who do laparoscopic. When, for example, they've had prior surgery in their pelvis or retroperitoneum, they have a lot of scarring on their sacrospinous area. We've done a combined surgery where the OB-GYN or the pudendal surgeon has done that part and done the sacrospinous approach, but they haven't had experience with the piriformis and distal decompressions, and then I've done those decompressions. So it's just important to know that there's many sites of compression and all of these different approaches have their place.
So now, if we could talk a little bit about your approach. I know a lot of people in the group have kind of compared surgical notes and they're kind of talking and wondering what you reach. And I'm like the next few questions are very similar, I feel like. So, can we just start off with asking where do you make the incision and where did you learn this technique?
Yeah. So I will start with the last part. So I joined Andy Elkwood about 5 years ago, 5 6 years ago now. And after my training and after being at Georgetown, and he was doing pudendal nerve decompressions at the time, and so he turned me on to this path and this field, and I credit him for showing it to me. And what Dr. Elkwood taught me was the ischiorectal fossa approach to Alcock's canal. And we've since modified and added some other things, but what we started doing was just an ischiorectal fossa approach transcutaneously. Um, but we also do a transgluteal interligamentous approach, and I do a transgluteal piriformis approach, which is a different incision. And I also do the anterior approach to the pubic ramus or base of the penis or clitoris for people that have refractory dorsal nerve pain. So the which approach just depends on where you have it. Most people have it at that ischiorectal fossa area, which allows me to access Alcock's canal, the rim, and the sacrotuberous and sacrospinous ligaments. So I can get the ligaments from my approach.
Okay. And can you go into explaining the advantages of this approach compared to others? And do you consider this approach less invasive?
Well, the benefits of this approach are that it allows complete visualization of the interligamentous space and Alcock's canal to the transverse peroneus muscle. From my understanding, and again, I don't do a laparoscopic, I've only read and seen videos of it, but I haven't had the privilege to see one in person yet. But from my understanding of these, um, the approach is retroperitoneal through the sacrospinous ligament, and then they proceed to dissect. Usually, what I read is as much as possible into Alcock's canal or proximally towards the piriformis. That leaves the distal Alcock's canal and its fascia still undissected, and it leaves potentially the piriformis undissected. I imagine. I don't know how folks are getting to it, but it could be. Um, so is that more invasive or less invasive? I have no idea. For me, I would rather someone just make a cut on my keister and go right to it and be done. For some, they don't want that cut over there, or they're mindful of the scar and they'd rather have three small scars on their abdomen. When you go through the abdomen, the risks are you could hit abdominal organs and cause serious injuries. Going through the skin on the butt, there's not really a risk of damaging anything except the pudendal nerve, which we're going for. Um, so I don't know if I'd say it's more or less invasive. It's just different.
Okay. So now these are going to be very specific, as you know, I sent them ahead of time, but um, so how far into the ischiorectal fossa can you follow and decompress the inferior rectal nerve?
All the way, all the way, all the way to where it enters the anus. And
Okay.
I've had people who have had pelvic congestion where they've had it ligated and they had a stent and they had a decompression. And then I'd see just these veins hanging off the inferior rectal nerve that I've had to then chase with a microscope and ligate. Pretty interesting case.
Hmm.
But yeah.
And then how far can you follow the perennial branches? Perennial branches. Sorry.
Technically, I can follow them as far as anyone wants, depending on how big the scar is that we agree on. But in general, I follow them to the into the perineum. So there's a muscle called the transverse peroneus muscle, and we always follow it to past that muscle.
Okay. And I think you answered this one previously, but just going to bring it up again. When you're operating, do you evaluate all the other nerves around, the general femoral nerve, ilioinguinal, and posterior femoral
Oh,
cutaneous?
those you can't see those. Impossible. I we evaluate those in preoperative consultation.
Okay.
That's when we think about those. In the most pudendal nerve approaches, you can't see any other, there's no other nerves with it except for that proximal part where it's by the sciatic and posterior femoral cutaneous.
Okay.
Yeah, and you
And
also, a lot of people ask this, you also can't see the right pudendal from the left pudendal or vice versa.
okay. And then can you approach access the entire Alcock's canal, including the
Yes.
distal exit points?
Yeah.
Okay. And then can you still reach the interligamentous space and piriformis region through this approach?
No. You have to make a second incision to get to the piriformis, or I have to make a really long incision. I prefer to just make a second incision.
Okay. And then for patients with suspected scar tissue entrapment in the deep perineal and dorsal branches, can you decompress these via a perineal approach?
I can. Yes. Yes, that's exactly right. For that problem, it's a different approach, not the regular ischiorectal fossa approach.
Okay. And then what percentage of your patients develop problematic post-operative scar tissue? And is there anything patients can do to prevent this?
So, how do you prevent scar tissue on nerves is a $1 trillion question that a lot of companies have been trying to solve. Right now, we use a product called Axigard HA Plus. It's porcine submucosa with hyaluronic acid. Hyaluronic acid is the same thing that goes in Juvederm or facial fillers, which is very, very, very safe, resorbed by the body very well, minimal reactivity, and it's very slippery. Since using this, and I've been disappointed by many nerve wraps and protectors in the past, as many nerve surgeons have, our actually issue with reoperation due to scarring has dropped precipitously. Um, so the one re-op I have had to do for a pudendal after using this, it it was not because of scar tissue, it was for something else, but it made a beautiful plane. So yes, scar tissue is a thing, but I think there's hope, and I think that the hope may even be here and stuff is getting better. The best thing you can do to prevent scar tissue from the first place is, when you have your surgery, avoid fish oils and things beforehand, aspirin. Just try not to have a pro-bleeding state going into surgery because bleeding around your nerves is pro-fibrotic and it's going to cause more scar tissue around the nerves. So we're pretty strict with keeping people around for about 4 or 5 days afterwards because if we notice they have a lot of bruising or bleeding, we'll take them back to clean it out, not because it's life-threatening, but because blood around the nerves can cause more scarring.
Okay. And if pain is caused by a fibrotic or inflammatory environment rather than a mechanical pinch, how does your technique address that?
A mechanical pinch it's kind of the same but different. So fibrosis or scarring usually affects a region, like it'll affect several centimeters of the nerve, and it's usually not focal. Whereas an anatomic entrapment, it's usually a very small area that's pinched. Like there was one mistake made in us where it pinched the nerve, and so the sacral tuberous ligament is just cutting right through it, or like the distal part of Alcock's canal is just cutting right through it.
All right, so let's talk about recovery. So,
Okay.
what does recovery typically look like after surgery?
There's two parts to recovery. In part number one is just the skin healing, and that takes 6 weeks. So 4 to 6 weeks until folks are able to sit without a cushion or needing to turn the other cheek. Nerve healing on average takes 4 to 6 months. And what I mean by that is for those months, what we want to see is that you have some change in your pain, but it's going to be like the stock market. It's going to be up and down as you get there, meaning you're going to have some days that the pain feels great and some where you feel like the pain will be back. It's very common immediately after surgery because we use a long-acting numbing agent that people feel really good for the first week or so, even the first few weeks. Very often around through weeks 3 or 4, there's a phenomenon where they have an increase in the tingling and pain and paresthesias. That's because when small nerves are manipulated, they essentially pause, they go into a spasm for about a month. And so after that month, it starts this nerve regeneration process, which kicks off this tingling and burning type of feeling. I tell everyone about this so that they can tell us, and we'll give them steroids, which often helps that process.
Okay.
And then for PT is dependent on if that person has pelvic floor tightness. If they don't, I don't routinely recommend PT. If they do, PT can be a useful adjunct. Um, Steroids, as Dr. mentioned, are also a useful adjunct after surgery. And sometimes we not only use them by mouth when they have that 1 month sort of tingling, but if it's months 4 or 5 or 6, and they have an improvement, but they still feel like they still have some pain, we'll often use a steroid guided nerve block to help break up any sort of scar tissue in that region and enhance their outcomes. Dr. Ferro, I don't know if you want to talk about steroid or clerics or any of the things that we sometimes inject during recovery to try to enhance people's outcome.
Um, yeah, so first of all, I apologize for earlier. I didn't realize Sesame Street was playing in the background when I was talking. But yeah, so I do the nerve blocks again post-operatively, sometimes with steroid, sometimes with platelet-rich plasma, which we've been seeing good results with. And then I'll also use an amniotic tissue injectable, which Dr. Lakhiani mentioned. Pre-op, if you have a compression, those things really aren't going to work as well because they're not going to mitigate the compression site. But post-operatively, once everything's kind of opened up, these things have a tendency to work much better and help kind of speed the recovery process and help with the healing. So, those are some of the different modalities. And then also there's things like peripheral nerve stimulation and spinal cord stimulation for um, some of the patients that have a little bit more complex healing, but we don't often have to use that. It's usually just injection that will work better for this.
And how often do you do the injections for patients? Like, would you say, and are they usually, you said 4 to 6 months is pretty common, so is that the time frame they usually go in for injections if they're going
Yeah.
to get injections?
So yeah, I will defer because I'll always, whenever there's a surgeon involved, I always want the okay from the surgeon to be able to inject. So usually Dr. Lakhiani will send these patients back when he feels that, they're ready or if they need it. Um, do you have anything to add to that?
Yeah, so no, that's exactly right. It totally just depends on the person's recovery. Everyone's different, and to kind of walk us through 3 different scenarios. There's scenario one, someone who's had their pain a year and a half, 2 years, they get their surgery, they have post-op discomfort, soreness, they post-op may feel an increased tingling, burning, but by month 2, they're feeling better. They think their pain is, a dull ache. By month 3, they're back to activities, they're running, they're doing sports. By month 4, they've kind of, feel like a scar and some tugging and maybe some dullness over there, and that they take Advil or Tylenol for, but are hopefully not thinking about it. That's a common scenario. Another common scenario is someone gets their surgery done. They do okay post-op, or they may have worsened pain post-op, and they require steroids potentially for a long time, maybe a month or 2 months, as we try to reduce the inflammation on that nerve. Typically, this involves people with a serious traumatic insult or long-term compression. They often have a longer recovery, and we kind of predict this intraoperatively because we do intra-op nerve testing to see if we have any sort of immediate nerve improvements. The folks where I see some kind of a change in the nerve stimulation, I can pretty much tell that, hey, they're going to get better, but it may or may not be a long and hard road for them. And some of these folks may take the full 6, 7, 8, 9, 10 months, but they say, it was really rough. I was down for a lot of days, but then I noticed the days started getting better and they got better. The concerning patient is the one where, they get to month 4 and they say to me, Chris, it's not worse. It's not, but it's the same. It's exactly the same. That usually indicates to me that, we didn't get it. The first two situations are, we got the nerve, but it's healing itself and it takes time and it may incompletely heal. In that third situation, the questions I ask myself are, A, did we make the wrong diagnosis? Was this not pudendal nerve entrapment? B, did we not fully release all of the nerve, the full nerve, meaning we released this curectal fossa, but maybe we didn't release the ligaments and we should release the ligaments, or we didn't release the piriformis, or we should release the piriformis, etc. Or three, is it that it's been too long and the nerve is just atrophied, it's dead. The analogy I usually give my patients is, listen, if you put a gauge earring in someone's ear, right, and you take it out, the ear is still a big hole. If you pinch a nerve and you leave it pinched for a year, 2 years, 5 years, 10 years, and you unpinch it, it's not going to be a round, glistening, healthy nerve. It's going to be a pancake where it's being pinched. And so some folks have had such a severe pinch, or so long that it's been pinched, that there's a morphological change in the nerve, meaning on visual inspection, it just looks different. It's not a good quality nerve. And that's the type of nerve that I worry may not recover. And usually electrically, we see that there's no improvement. The question in those folks is, what do you do about that? Because that's a damning sort of diagnosis. And the hard part is that in the arm or the leg or the face, when this happens, we cut out that damaged nerve segment and we do a nerve graft, like I said I was doing. But you can't do that in the pudendal nerve without making someone incontinent. I'm yet to find the patient that said, go ahead and make me incontinent, graft my nerve. Um, but that's the trade-off. And that's why the outcomes for PN are never going to match carpal tunnel syndrome, because the delay to diagnosis is too long and we don't have all the treatment options available. And also part of the areas that it gets compressed are very dangerous.
Yeah. Would you say that there are certain things people can do to, I'm going to say, better their odds? I don't know if that's the right way to phrase it, but let's say, like, for instance, would it be beneficial for people not to sit, to potentially like not aggravate the area? Would obviously most people I don't think would get back on a bike if, say, that was their cause, but like, would avoiding things like that, would still using a cushion be beneficial? Things like that. Would you
I
say the
think
odds are better that
with
way?
reason, a lot of these things are helpful. Like bicycle riding, squats, motorcycle riding should be off the table. If you've had this, you never want this again. Um, Sitting is, I get that one all the time. And the answer is, I don't know. In general, I think if you're in pain, don't try to fight through it, because the pain always wins. This nerve always, always wins. And I don't think it's healthy for people to have that sort of biting on leather sort of attitude about their life 24/7. It's a very difficult way to live. So in general, I think be kind to yourself. Don't try to push through this. Let's just solve it. But your point's well taken that there are things that people shouldn't do, which can definitely aggravate this. And those are the ones that we know about. The hardest one for me to answer for folks is always pregnancy. When women have had this from childbirth and now we treat it, but now they want to have kids again. That's a very difficult question.
That's actually on here. Do you have any
Oh, great.
do you have
You
any
know, I
feedback
have
on this one?
patient. I have patients who've asked me this. I've had family with PN, and it's hard. The good news is that if I can reassure anyone here, of the patients I've had who got treated and then got pregnant, they all redeveloped it in pregnancy, but it always went away after. That's not many people. That's like 5 people, because there's not as many young women pre-pregnancy with PN, but if that helps.
Yeah. So if say some surgeons will say it takes like 2 years to heal. In the majority of cases, is that like the majority of cases or is that like an exception? And if someone has no improvement after 1 year, can you reasonably conclude that the surgery is a failure?
Yeah. Um, so that's based off of, our theoretical knowledge or bench knowledge of how nerves heal. Yes, 2 years is the bench answer. Most folks who've talked to me know that I say 4 to 6 months, we basically know. I have a handful of patients that said at month 6, it's not better, but let's give it more time. And then by month 8, they're like, yeah, I do feel it's better. But for the most part, I think around 6 months, you have an idea of where it's going. And that's why I say what I look for is there a change in your symptom characteristics? If you're at month 5 and you say to me, feels totally different, it was this sharp stabbing, hot poker is what I get a lot. And now it's an ache, it still hurts, but it's an ache. Fine. Usually that means it's just healing and it needs more time. If before they had, pain with defecation, but now they only have perineum pain, fine. That's a change. Um, the head of the penis is always the last thing to feel better because it has the longest time to reinnervation just for the nerve to get there. So folks ask that, but the clitoral and penile things are just always last. So anyway, short answer to your question is I think at a year you generally know, but I don't think it's wrong to begrudge anyone to wait a full 2 years. I think that can often be wise.
And when ligaments are released, how do you address the potential impact on pelvic and hip stability? And is there
It,
a risk of
this
fading?
is the $1 million question, right? I would love to get in a room with all the Pudendal people and orthopedists and just a couple cadavers and some AI machines that could look at pelvic kinematics and figure this out once and for all. Um, the answer is that if you polled orthopedic surgeons, as I have, about the importance of the STL and SSL, they're not very important. If we look at the literature, it says they're not very important. However, there is at least, like we were saying before, some hypothetical or theoretical thought that the lysis of these ligaments um, can lead to pelvic dyskinesia. But in some people, the presence of these ligaments is what's leading to pelvic dyskinesia.
Right.
So it's kind of a damned or you do or damned if you don't. That's why I have taken the approach, and I think Dr. Osman, somebody told me from this group actually, is doing the same, where I do the ischiorectal fossa approach, and then I examine the ligaments myself. And I find the pudendal nerve, and I see where it goes through the ligaments, and I dissect above and below it, and then I just look. And if I can put my finger or an instrument between the ligaments, and there's nothing on the nerve, I leave them. And if something's compressing, I have to cut it. Otherwise, you're still going to have the problem. Some people tell me, they say, even if you see it compressed, don't cut it because I'm afraid, and that's fine. At the end of the day, I work for my patients and I'll do what they ask, and I take a video or a photo to show them. But that's the answer to that question, I think, isn't should we do something else? It's who should we cut the ligaments on?
Right. All right. Have you had any success reducing or eliminating rectal or vaginal spasms in patients whose spasm appeared nerve driven?
Interesting question. In general, I'd say if you have a spasm, try Botox. If you haven't, I have had one patient who had that, and we did the decompressions, and they did say that it improved. It was so crazy. I wish I had a video of this. I'll never forget this case. They had a pure, they had a ligamentous band, like a falciform ligament in their Alcock's canal, and it was pinching it like a tether, like like this tightrope, just bang right there. And I was with my PA, and I saw this, and we snipped that off. And as soon as we did, everything. You could see their anus and their vagina just start pumping, spasming right in front of us, which is actually not that unusual with pudendal nerve entrapment decompressions. As soon as you decompress it in some people, you start to get immediate fasciculations. It's true with people with upper extremity compression disorders, lower extremity ones, etc. So folks who have pelvic floor weakness or spasm or tightness can definitely be from the nerve. And we've seen that immediately many times.
Hmm. So this one I know you've covered, so we might revisit it again. But what are your thoughts on the placental allograft for PN?
I'm gonna let Dr. Ferro answer that one because she does that for us.
Yeah, so I do an embryonic tissue injectable, and I have found actually, and I have used it on patients non-surgically. It's called Clearix Flow, and we have had good results with it in terms of helping to dampen their pain, and length of it, duration of it is anywhere on average, I would say like 6 to 7 months.
Wow.
Um, the thing about it is that it is not FDA approved. It's FDA compliant, but is not an FDA approved treatment for any, I guess, nerve pain. And so it's also not covered by insurance. So it is an out-of-pocket cost. But there are properties that help specifically with nerve pain and to help with some of the healing of the nerves. So I've used it other places in the body too. And the patients, all that I've used it on, have had really good response and good things to say about it. So yeah, it's an option.
Okay. All right. And then how do you feel about implanted neuromodulation devices? And I presume this would be something you would consider for a patient after surgery has failed, if I understood you
Um,
correctly.
if I could personally, I would use one of these in almost every case. The problem with PNS right now is just getting insurance to pay for it. So that's hard, and the out-of-pocket expense is very high. It's like 30 grand. Um, I think that if I could put in the lead for this for most patients, I probably would because I think it's very benign. And I think the having something extra that somebody could turn on any time in their life if the pain came back, I think is pretty cool. Um, and there has been some success with these. So I think that there's runway to go in terms of studying them. Um, but yeah, I'd kind of leave it at that. I'm not sure that it replaces surgery because it doesn't fix the problem. It just masks the problem, but it can work for in that use also. Um,
Well, let me
usually,
ask this actually. I don't know why this just occurred to me. Do you actually do surgery on patients that already have stems, or does it become problematic?
no, we can do it.
Okay.
Depending on the type of stem, it might add some additional, technical considerations, but no, I can still do it.
Okay. And then do you have any recommendations for treating dorsal branch allodynia? In, for instance, if it was caused either by PN, right, or by a procedure like RFA. I know some people will get allodynia from that as well.
I have no good treatment for post-RF related things.
Okay.
Unfortunately, I think it's like steroids. Maybe you could consider a PRP or something like that to try to help it. I don't think surgery is probably the right answer. For base of penis, isolated dorsal nerve pain, though, I would say that the the fourth site of compression or the dorsal nerve compression points are very overlooked in this country. In Europe, and especially Vienna, it's much more picked up on. But here, since Dr. Dellon retired, it's missed. And just consider you may have a dorsal nerve compression, which is an isolated thing, and it's much more successfully treated in men than women.
So now we're just going to get to logistical kind of questions. What is your current like wait time for consultations or surgery?
Oh, we're on to the easy section.
Yeah, the easy section.
Okay, all right. Um, I'm usually booked a couple months.
Okay.
But just reach out and we try our best. Whenever we start hearing that we're backed up, we've done things like open up weekend hours or something like that because we definitely understand people are suffering and want to be seen. The best thing that folks could do is just have all your records ready. And if you even have like a typed summary of your history, if you have a long history, if you don't have a long history and this is fairly new, that's okay. If you have a long history, like sometimes folks do, the more, you can kind of make those presentable. So it's not a lot of sifting through different medical records. That would help speed things up for sure. Also, your block history is probably very important. A lot of times we have meetings with people and they're like, well, I did have a block. And we're like, well, did it work or not? They're like, well, I don't know. And then I'm like, okay, well, let's get you a block. So oftentimes folks, what would they do now is when they call us, they'll get in touch with my call center. Our call center folks will get your name and information and demographics and ask you some quick questions, tell you what they need you to get. And you're going to get a call from one of my PAs, Jess or Adriana. And they're then going to spend an hour talking to you about your disease, what happened, the full workup. I've taught them everything I know about pudendal neuralgia. So they should be able to answer most of your preliminary questions and get things sorted. If there's any additional information that they need you to send, definitely send that over because we need all of that to get the appointment with me. That's usually the biggest holdup, honestly, is just folks getting records over to us before we do the appointment. Because, if we have the appointment, we don't have everything, it makes it very hard to pick this up, because it really is a diagnosis of ruling out everything else. And if I can't confidently feel like I've done that, I don't think I'm doing a good job for you.
And do patients need a referral to see you, or can they contact your office directly?
You do not. You can contact my office. You can go to chrislakhianimd.com and there is a button that you can use to book a consultation. And most of the stuff we talked about here about PN and other nerve disorders, I actually really like making little educational websites and they're up there too.
Awesome. And do you collaborate with local pelvic PTs or pain specialists? I know we discussed a little bit that you guys are expanding, so you're hopefully going to get.
Yes. Thank you so much. I can't believe we almost didn't mention this. Okay, so super exciting news. Dr. Ferro and I are starting a neuropelvic pain multidisciplinary clinic. That should be hopefully debuting in the next 2 months. It's going to be myself with reconstructive microsurgery, Dr. Ferro with PM&R, our new partner who joined us, Dr. Alex Shu, who's a reconstructive urologist, inner dynamics, physical therapy. These are PhD level pelvic floor PTs. So they're the best of the best. And we're going to run this out of our office in Red Bank. At some point, I will fold in an OBGYN. We're still looking for that. But this should be a great stop. We're hoping for people to really get world-class boutique care, a multidisciplinary evaluation, and because most of our patients come from out of state or out of the country, that they could fly in, be able to see me, get their injections with Dr. Ferro, get a PT eval, get a urology eval, get their blocks, see me again, and then like we have a plan, instead of this process, which right now takes oftentimes months, if not years, and we are trying to shorten that.
And then speaking of patients traveling from out of state, I know earlier you had mentioned, so just want to clarify, how long do you recommend people stay, especially after surgery?
4 to 5 days. Usually folks will come in on Monday. I'll meet them again, sometimes for the first time in person. We'll talk, do our exam. I have a presentation we go through that just talks about a lot of the stuff we talked about on the call today, including with other people's pictures or videos of what the surgery looks like. Um, we agree before you come, we've done a telemedicine and talked and made sure we're a good fit. And I tell everyone, if you decide to cancel because you don't like me or my haircut or whatever, that's totally fine. You can cancel. Ditto, I have to be able to cancel, if I think you don't have pudendal nerve entrapment, and that's happened once, but it's happened. And we do the surgery on a Tuesday. We keep you in the hospital overnight, one night for your convenience. My team sees you Wednesday morning. You stay in a hotel until Friday. I see you on Friday. We go over your operative video, your intra-op EMG results, in general, what we found during surgery and your recovery, make sure that you're doing well, make sure that you've been able to go to the bathroom. And then we continue to follow up over telemedicine at your 3, 6, 12 week visits, and then 6 months and a year,
Okay.
and unless you have a problem.
And then I know we mentioned this and I forgot to add it in the interview earlier, but do you have any things such as restrictions on what people should or shouldn't do before surgery? Like, for instance, smoking was brought up. Um, do people have to stop smoking and drinking? I
Yeah.
don't know what other things could
Yes.
be.
Stop all the bad things.
Stop all the bad things.
Yeah. Smoking. Thank you for bringing that up. Smoking is the worst one. Smoking decreases the size of your blood vessels by about 50%. So the diameter shrinks 50%. That means that you're getting to the fourth power, right? Is Broussais' law. So way less blood than you otherwise would normally get, which increases your wound dehiscence rate and infection rate. And the ischiorectal fossa approach is done not on, but near the anus. So you can imagine if you have a wound healing problem and then stool gets there, you could get an infection, and that would lead to infection around the pudendal nerve, which could lead to severe crippling pain for a lifetime. Infections around nerves cause a problem that is very difficult to fix without cutting it out and grafting it. So, absolutely no smokers ever for this, for your own safety. Other things to do are just like we mentioned, just avoid anything that could increase your risk of bleeding so it doesn't bleed around the nerve, and then mitigate things that hit air in the pelvis, cycling, squatting, things like that.
Okay, so let me check real quick, just in case somebody had any clarification questions on there, except for some reason it won't show me. One second.
I can't see anyone else. Are they
Yeah, so it's
watching
on
you?
Facebook. So
Oh.
let me see. I might have to go on another device because for some reason it's not letting me look at that. But I just wanted to make sure that if somebody had something, let's see. I thought I saw something that someone asked for clarification on. Okay. Do you take patients that don't have because you guys are New Jersey, so insurance wise, do you do any out of pocket patients?
Yeah, self-pay. Yeah, you can do cash pay. It's an option. You can call the office and talk to them about it. That part I don't control. You'll have to talk to the office.
Okay.
But I know we've done it.
Have you
In
ever,
general, though, I will say one thing that I only do that for people who have had a full workup or have the means to otherwise get the rest of the workup.
okay.
So if you if you have all your diagnostic tests, positive blocks, all of that stuff, and then you're like, well, my insurance ran out. Can I pay cash? That's one thing. If you don't have any testing and no insurance, it's very difficult because I don't know how to do all the testing and things for you then.
Okay. And let's see. Have you ever done surgery and found the person was not entrapped?
So it's funny, this question of can you tell entrapment by sight? The answer is maybe we can. Sometimes we do this and we're like, that was super tight. That's definitely entrapped. Look at the nerve is pinched. And sometimes we do this and we're like, this doesn't seem entrapped much at all. So yeah, that does happen. I had a case recently like that, but that patient still felt better. So I don't know how much sight is useful.
Okay. Um, let's see. Sorry, I'm scrolling. People are typing.
No
Um,
problem.
let's
How
see.
many people are joining us?
Currently I see 46. I know a lot of people
Okay,
are going to be looking at it later, on YouTube. Oh, now it
that's
jumped
great.
up. Let's see. Oh my gosh. Okay. Hmm. Da, 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 da. Once the veins, if trapped around the nerve, is surgically removed, how long does it take for the nerve to heal, and will the symptoms start to go away?
Same timeline as before. If whether it's the nerve that's squeezing the nerve or a ligament or something, it's still being squeezed, so it just takes the same time to heal itself.
A lot of people are asking similar questions about the out of pocket, whether you take insurance. Sorry. Let's see. Okay. Can the femoral nerve cause some of these specific symptoms as opposed to PN? And if so, is the nerve simpler to decompress?
I'm sorry, I didn't quite catch that.
Um, this person asked, can the femoral nerve cause some of the similar symptoms as PN symptoms? And if yes, can that nerve is that nerve simpler to decompress?
The posterior femoral nerve can cause symptoms in the back of the thigh and medial upper inner thigh.
Okay.
So the thing that it could share with pudendal nerve is usually upper inner thigh pain or burning or tingling. That's usually their overlap. I don't think the PFCN is easier to decompress, actually.
Okay. Um, yeah, a lot of people, I think they weren't here earlier. I can ask for clarification, but is there a timeline within which PN entrapment can be decompressed to ensure success? I think you've mentioned 2 years is ideal.
Earlier is better. There's no guarantee with any nerve decompression, but earlier is better.
Um, Another clarification. Do you get the distal branches?
Yes. The question is again, they may have missed earlier, is how distal, and it's like, yes, I get the distal branches. I think most people are thinking of by Alcock's canal. I also get them distally in the front, if you have those issues too.
So this one I think might be for Dr. Ferro. Um, how do you know if the needle hits the right spot? And how does a person know if the injection is truly qualified, or if the injector, like the person, the medical professional who's doing it, is qualified? Are there any, like, is there a good way to find someone who's qualified to do the injection?
So in terms of, if it hits the right spot, you'll know within like 15 to 20 minutes if you get numbness. He used to have my patients wait, but I've just gotten so good at doing them. I just give them the pain log and they go home that night. And I don't know that unless Dr. Lakhiani knows better, but I haven't really had anyone that's come back that said I experienced no numbness. I don't think the block was effective. Um, and then in terms of an injector, that's difficult because in many parts of the country, there's people that can't find anyone that does them at all.
Right.
So, I think just someone that is experienced and someone that actually does, is familiar with a pudendal nerve block. Oh yeah, I do that. They probably have enough experience to do the injection. And they can actually be done without any image guidance. There's a lot of urogynecologists that will do it just by feel. And they, OBGYNs do those blocks all the time or with labor. So they'll do pudendal nerve blocks to numb the whole pelvis. So that is also a good way to do the injection. I don't know that there's necessarily a way to know that someone's qualified, but if they're experienced with pudendal nerve blocks, most likely they're able to do it.
And do you find that the X-ray, because you do X-ray and ultrasound, do you find
Mhm.
that CT guided or X-ray or ultrasound is better? Is there one that has a higher chance of hitting, I'm going to say the correct spot, if you will?
Yeah. Usually that CT guidance has always been considered the gold standard. I think just because the imagery is so good with it. That being said, we've had plenty of people that have had some CT guided injections and it just wasn't as effective. So um, I don't know that one imaging modality is necessarily better than the other. CT guidance is supposed to be the best, but yeah, I think it is just having, doing a high volume of these injections um, probably has a better outcome. But the reason I use the two modalities is just to ensure that I get numbness for my patients, and I think it just gives a better result. That's the only reason why I use the two imaging modalities, but I don't think one's necessarily better than the other.
And
And
do you
sometimes people
ever,
have anatomic variations too, so that could be why, you know, you're not necessarily getting numbness. But go ahead,
and
what were you
do
saying?
you ever put people out for your blocks? Because I know that's another common thing is some people will want to be put completely asleep. Do you guys have
Yeah,
the ability to do that?
we do. I try not to because I think that sometimes having the anesthesia, because you're only going to get that numbness for a few hours. Sometimes it'll last into the evening, and even though it's conscious sedation, so it's like the same kind of anesthesia that you'd have when you go for a colonoscopy. When you wake up from it, I think it's sometimes harder to tell uh, how effective the block was. Sometimes you're still groggy from it. You might go home and just like kind of fall asleep and not keep track on the paper. So we really like if you can do it without the sedation, that's always the preferred way. And I think it's just better. But we do have that option. Sometimes I'll just give if you need it, if you get a little anxious, we can give you a Valium or something to take beforehand. But if you absolutely do prefer to do it, just take that 10-minute nap and have it done that way. We do have a surgery center where we can do that.
Okay.
But I
Um,
agree with Dr. Fair, though. In general, I've had many patients tell me that when they had their block, they were put under and they couldn't remember their result. So that's the key is just you have to be able to remember the result.
I think some of these are out of order. Okay. Have you come across PN compression due to endometriosis? And if so, how did you treat it?
No, no, I'm curious about this topic in general because people have brought it up to me. In general, extraperitoneal endometriosis is quite uncommon. Um, so it would have to be quite unusual to get, you know, endometriosis outside of the abdomen, into the buttocks and groin. Could you get it retroperitoneal, meaning by the sacrospinous ligament? If you've already had surgery, I guess that's like a theoretical. I think we could probably find some like off rare instance cases where something like that might happen, but in general, no.
And then for clarification on your success rates, how do you gather those success rates?
At 1 year with patient follow-up on VAS, so that was just, asking patients like, how do you feel, on a scale of 1 to 10, and at various time points.
The There's so many comments. Some of them are just general comments like glad to hear about the new clinic. So we have some people that are saying that.
Nice.
Thank you for the interview. Um, so grateful that both of you are taking the time on your Saturday to talk to us. So I'm sorry, I'm scrolling through all of these trying to
Oh,
find
that's really nice. Yeah, no, that's great.
let's see. Okay, my understanding. Um, so someone mentioned their understanding is if the nerve is burning, that there's still life in the nerve. Is that a correct assessment or
Not not really. Like we know people with phantom pains can have burning phantom pains, and they don't have it. Their nerve is cut in that instance. So unfortunately not. And that's why we have to graft in those cases.
and speaking of for patients that have numbness as a symptom, do you find some people have mentioned that their surgeons say that that's actually means it's worse off because it means that there's no
Yeah, it was
life in the
compressed for
nerve?
longer or whatever.
Yeah.
Uh, so numbness is tricky because the vast majority of the time people are talking to me about the numbness. What they're talking about is subjective decrease in erogenous sensation. When uh, I think of numbness, I think decreased pinprick sensation. And if we read the nonce criteria, one of the criteria for even including this is no objective sensory impairment, although there's some caveats associated with that. So I think it depends on the type of sensation we're talking about. The objective sensation, I would say, is actually probably more readily treated, meaning, hey, it feels kind of numb and tingly. The lack or change in erogenous sensation is a very complex topic where what I generally tell folks, because I get this a lot, is that PNE surgery is not designed with that type of patient in mind. Like when they were thinking about pudendal nerve entrapment, it was the folks who were having pain with sitting and bowel problems and stuff. So the criteria aren't the same. I think it's actually a different problem that somehow gets lumped into pudendal neuralgia. In my earlier career, I did do surgeries on some folks who really asked for surgery when they had objective or subjective, I should say, change in their sexual erogenous sensation. It was only later that they told me they really only meant that type of sensation, and didn't get any difference. So that's my only caveat is if it's for that, I would really think hard about surgery. None of the success rates apply for that type of issue. And just think carefully about it. I might try other things like PRP or what Dr. Ferro said.
And then for patients with PGAD, do you have any? I know PGAD is an extremely difficult condition, and there's
Extremely,
it's just so hard to
extremely.
know if surgery would even help patients. Have you personally experienced any patients that have gotten better or their PGAD has improved with surgery?
I've experienced, yeah, all of the above. It's I've had people get better with their PGAD. People who got better with PGAD had very specific focal pain only in their ischiorectal fossa. The people who did not, I could palpate multiple areas of irritation on them. Have had at least one person where I even did dorsal nerve neurectomies and I cut it because her PGAD was so bad. Um, and it didn't take away her PGAD. So I don't know. With regard to that, I would say it requires a lot of study. Um, Tune back in when I have more gray hair, and I'll let you know if I have a better solution. But we're working on it.
Let's see. Oh my goodness. Will PN release actually help the severe bowel dysfunction, like with chronic constipation and symptoms like that?
Not, it won't help you go, but if you're not going because you're guarding due to pain, it may help. So some patients patients have told me about the very extreme pain that they experience when defecating or even urinating. So if that's the issue, definitely, because pain is overall the number one issue treated by the surgery.
Have you ever heard of PN being caused by antibiotics?
Um, I've definitely never read it in the literature. I can't think of any patient that's told me that they feel like it. There are certain classes of antibiotics that are neuropathic, but usually they affect small nerves in like the arms and like the hands and feet.
I'm not sure you can answer this one, but I can ask it. Do you know what happens to cause the feeling of the golf ball in the rectum? Like, is there a
Like
specific,
what the exact pathway is?
yeah.
No. No, I think I hear everything. Like some folks have told me the golf ball, a rock, a poker, a cattle prod. I've had folks tell me it's burning or dry. I've even had folks tell me it feels like a wet towel. So it's a nerve. It can feel anything. I think it's interesting that it often settles on a golf ball, but could be anything.
All right. I think scanning one more time just to make sure I didn't miss anything. Um, Kind of an interesting question. How close to the rectal opening is your incision?
Um, it's I don't know. I guess about 4 inches away, 3, 4 inches away. It's you want to feel where your bone is that you sit on, and it's basically right on the inside of that bone. So you don't want to sit on your incision, and I can't make it on the other side of the bone. So it's just right on the inside of it.
And I know some patients have asked this in the group. This isn't actually one that was on here, but some people do have bilateral PN. Do
Yeah,
you
like 30%
operate?
ish if people do.
Yeah, do you operate on both at the same time, or do you prefer to do
Never
one side at a time?
one side, all the
One
way for
side.
your safety.
Okay.
Because if you get a pudendal neuropraxia is anytime you touch a nerve, you can cause it to spasm and just shut off. If you cause that on both sides, you're making someone functionally incontinent, potentially for weeks. Um, and they will not be happy. and it will not be a fun recovery for them. So better just wait a few weeks, make sure you get better, do the other side.
Let's see. Public. That's kind of a detailed. Um, I know you covered this one, but I can ask it. After surgery, does the pain get worse after anesthesia wears off before it gets better?
First few days, it's probably better because you're numb. Um, Honestly, when the pain wears off, after the anesthetic wears off, the numbing medicine, it's around day 4. And usually my patients don't need much in terms of pain medicine, except for the class of patients who do. And there are some people that they have their decompression and bang, a cycle of pain is just triggered. And it's going to be weeks or months of trying to get them down from this. So some people just have very intense reactions to A, pain, and B, the decompression. So while 80% of patients do fine, no narcotics, they go home. Some people have very intense reactions and maybe in a lot of pain afterwards.
And does PN travel to the legs and make them burn?
No.
Um, and I think this is might be the last one. It's hard because they're like coming in and I'm trying to refresh it so I can see them. But will the surgery help eliminate rectal burning nerve pain?
Yes, it can.
All right. I think we're gonna call that good. Oh, no. Oh, actually, I will ask this one because this is a common question that we get asked in the group. Do you happen to know why some patients will say like their PN nerve pain travels? So like one day they'll have this, the next day they'll have something else. Do you know why that could be?
It may not be PN. My
Mm,
number one reason for your pain traveling is it probably not pudendal neuralgia or you have other things going on.
right.
Focal pains that stay consistent are much more reliably treated. If your pain is going here and there, think think closely about surgery and make sure your symptoms are where the surgery is targeting very consistently.
So when you say that, like for instance, some people will say things like they have rectal pain or they have vaginal pain. Vaginal obviously could mean, I mean, that's it's a big area, right? So are you talking about like in during an internal exam, for instance, if like you're pressing on a certain thing and it's radiating elsewhere, would that be considered like that
No.
spot or no?
Well, what I mean by it is, let's say day 1, you have pain in the anus when you defecate. Day 2, you have no pain in the anus, you have pain in the foot. Day
Okay.
3, you have no pain in the foot, you have pain in the abdomen. That's
That
not a great surgical
right.
candidate. If you have someone that day 1 has anal pain, day 2 has vaginal pain and still has anal pain, day 3 has vaginal pain and anal pain, but also some perineal pain, day 4 they feel a bit better, day 5 everything's flared. That's kind of a common situation. It's all pudendal territory.
Okay.
They still do okay good, those people, but the folks who tell me, Chris, it's my perineum, I feel a knife over there every day, I feel it right now, it's right there. When you touch me right here, it hurts. That's the person that's the ones that feel better in 5 days, and talk about how great everything is. Like that's the ideal.
Um, what about decreased contraction upon orgasm?
Contraction of what?
I don't know. I was
I don't
hoping
know.
you knew. I'm not sure.
I don't know.
Um, let's see. Have you experienced any patients with vaginal mesh causing PN?
Oh my God, what a
So,
topic. We could spend a whole day on this too.
yeah.
Yeah, vaginal meshes or prolapse meshes, the meshes that are put in when you have a prolapse, they're usually anchored to the sacrospinous ligament. And I went in and then witnessed these, and this is actually what led us to incorporating Dr. Shu in our multidisciplinary practice is the fact that he has some experience with these meshes, and we get so many folks. It's anchored there, and sometimes that anchor, from what I understand, might even be done blind. So to get direct injury to the PN at the sacrospinous after a mesh, that's where my thought first always go to. That type of patient is a person that you should be thinking about the ligaments right away if they've had a mesh. Okay, that's probably where their problem is. And so if you don't, you've missed the diagnosis on them. Now, if you cut the ligament though, you're probably taking down their mesh because it's anchored there. So you give them mesh problems. Then they're going to go and be fine with their PN for a year or two, but still have their prolapse issues and leaking and then consider getting a mesh again. And then I've had this happen to me where the patient then went and got a mesh again and it caused the same issue. But then it was very hard to fix. So, yes, mesh problems can be fixed. Very common cause of PN. Hard to keep the job that it's doing intact after fixing it because you have to take down the ligament to address the nerve issue.
Okay. Um, and I actually had a question for Dr. Ferro. I know some patients will also get blocks for their piriformis as well. Do you ever do multiple blocks at the same time, or do you like to separate blocks? Is it,
So
if that makes sense?
preferably
I'm not sure.
yeah, preferably we'd separate them. It just helps us kind of figure out, how things respond. Sometimes we have patients that come from out of state and they're only there for a day and they can only see me for a day. So sometimes we can, if the schedule works out, we try to do one and they'll hang around for an hour or two and then we'll do the other area. But we do try to separate it. And then sometimes, we have someone that comes and we only have that one appointment time. So we'll do two of them together just to see if they even respond. And then if it's a question of, what does Dr. Lakhiani or one of our other surgeons need to do in terms of surgery first, they might have them come back to see me and say, hey, just do the piriformis this time or just do the pudendal.
Okay.
Right. We definitely get that it can be a pain to come back for these blocks, but remember, this is the only tool we have for narrowing down what is causing the pain.
Let's see. Uh, Clarification, because this did come up, because yet again, it's not very common. Do you actually do the internal exams, or do you have another doctor do the internal exams for those specific patients that you need them for?
Oh, but you can go ahead, Nicole Farrow. My answer is both.
Yeah, I've actually never been doing internal pelvic exams. Sometimes it's scary, right? These patients are in so much pain. You don't, your first time meeting me, um, I don't want to set off the pain or make it worse. And also, I had never been doing internal pelvic exams since I was a med student, which is many, many years ago. So I was relying more on the pelvic PTs because I do call them and talk to them, to find out what their findings are. But like I said, I have been working with an OBGYN now. So when needed, I will incorporate my an internal pelvic exam. But otherwise, I usually generally could, find what I need to find without it. And I think that's what Dr. Lakhiani does too, right?
Yeah. And can PN cause itchiness and
Yeah.
prickleness, I think is the word. I'm not sure
Mhm.
I'm familiar. Like
It
a
can cause
prickling
itchiness.
sensation?
Prickling, yeah.
Yeah. Okay. And I think that might be it. Oh, no, one more clarification for Dr. Ferro. What is the role of the placental allograft that you do? Like, what is its purpose?
It's just another treatment modality. It's another option for patients. It's kind of more in the lines of regenerative medicine. So there are properties in it. It's basically embryonic tissue. So it's healthy placenta and umbilical cord tissue that is cleaned and then freeze dried and made into a powder that we can reconstitute and inject into the areas of near the nerve that we're treating to help with nerve pain and then to help sometimes with some of the nerve recovery. So a lot of the time, the best option is after surgery. But if you respond well to a nerve block and you're wanting to try to just exhaust all your options before surgery, it's one of the options. So yeah.
All right. I think we're gonna call it because I feel so bad. You guys have been troopers. It's we've been on here for so long. So I just wanted to thank you like a lot for your time, your expertise, and your willingness to answer all these questions. I know a lot of them were very specific. Your work has made a tremendous impact on this community. Like I've said, you're a huge topic in these groups, and we're very grateful that you were able to join us today. Um, it's just, it was overwhelming. I know I can tell by the people in the comment section that they very much enjoyed this. So thank you so very much to the both of you.
Thanks for having us.
Thank you, Cora. Much appreciated. And thank you, everyone, for taking the time out of your afternoons to listen to us. I really appreciate this opportunity.
All right.
All
And
right.
to everybody listening, I will upload this video to YouTube, hopefully by this evening, so that for the people that missed it, or if you need clarification, it will be there for you. All right. Thanks, everyone.
All right. Thanks, guys. Have a good Saturday. Bye.
All right.
Bye. Thank you.